Okay, in this fifth block, we're going to review some of the immunologic, sometimes referred to as the biologic agents that are used in oncology therapeutics. And I have to sort of preface this by saying I'm certainly not an immunologist. This is something that's really, in a sense, out of my focus because things have evolved so much in the last decade or two, and these become very specialty agents. But I'll do my best to kind of walk through some of these, and we'll get the chance to talk more about them also in class. So we earlier alluded to the fact that immunology plays a key role in surveillance of cancer, and what these immunologic or biologic agents seek to do is to identify, particularly related to the subset of cancer or receptors on the cancer type or cancer cell, or something that's sort of unique to that cancer cell, to really focus on some area of really activating the body's or stimulating the body's ability to sort of do immunosurveillance. So the agents we have that sort of act here are either, this graphic sort of will depict, either things that are used to stimulate or things that are used to inhibit. And we'll sort of talk through some of these agents, some of the older and some of the newer agents. The interleukins and the interferons are older agents we'll briefly talk about, but have really gone by the wayside in that they are fairly nonspecific, have more toxicity associated with them. Where we will see, though, are the PD-1 checkpoint inhibitors used and some of the monoclonal antibodies that are directed against particular targets that are most helpful in practice. So we'll talk through some of those and highlight what is more or less important as we look at managing cancer in the current age. So we'll talk about this immunologic timeline here to kind of help us focus on, organizing our thinking with immunology. There's lots of different ways we can do that, but I think sometimes it's helpful to look at what kind of has happened over time, and then as we look at which agent or categories broadly or narrowly kind of came into play, we can talk a bit about what those agents are, how and how they're used today. So the first on this, on the left-hand side here, and a lot of these slides I have to sort of credit the clinician who prepared this, which is the source information is at the bottom, and she did just a really phenomenal job at sort of updating the role of immunologic therapy with a real focus on the checkpoint inhibitors in how we manage them in cancer these days. So her practice is in oncology. Mine is not, so I'm sort of relying and giving her full credit for sort of some of the slides that you'll sort of see here. So let's first look at the concept of immunosurveillance, which I don't really have much to say, nor did she, was just in the advent of the 1950s to even just be able to identify and be more specific about what the nature of immunologic responses were and how you quantify and qualify those in individual patients. So what's the whole role of immunosurveillance? But there were really no therapeutic options that would be sort of be considered immunologic therapy. In the mid-1980s, there was beginning to be some discussion of and some use of very non-specific immunologic mediators. And some of these are in the next slide or two. And these, again, as we alluded to, have largely fallen by the wayside, but occasionally you'll still see them used in some protocols. Most commonly in this regard are the interferons and the interleukins. And these are agents that are cytokines that look at sort of in a somewhat non-specific way will get a immune activation going. And they serve their purpose early on, but they're associated with lots of toxicities. They increase vessel permeability. They're not very specific to what they're doing. And so we have much better interventions now immunologically that are much more specific and better targeted. So these kind of agents have fallen largely by the wayside as far as therapeutics go. This graphic indicates the interleukins and the interferons. They're associated with bone marrow suppression. and other toxicities, including capillary leak syndromes, clinical depression. Largely these agents have been pretty much abandoned in therapy. The next group in the late 90s, mid to late 90s, was the advent of where we started to see monoclonal antibodies. And in this category, we're going to talk about a number of different groups that sort of either the monoclonal antibodies themselves or agents that are sort of in a similar nature to them. They might not be the monoclonal antibodies themselves, but sort of things that kind of tagged along with the monoclonal antibody movement. So monoclonal antibodies, first of all, we use them in lots of things beyond cancer, depending on the particular target they have. They're large molecules. They target a receptor on the surface of a cell. Depending on what the target is, we may see a different therapeutic use for them. So we use monoclonal antibodies in autoimmune conditions. The targets might be, in those cases, tumor necrosis factor or something else that trigger an inflammatory response. And we saw these agents used pretty widely and have been used for the last decade, 2 decades or so. What we see the targets are, here are them as they relate to targets used in oncology, are the HER1, the HER2 receptors. We also see CD2, CD20, receptors on B cells, or the VEGF receptor, or the CD52 or CTLA receptors. And so these agents commonly are Erbitux is a HER1 receptor and target. Target for HER2 is Herceptin is a common one. For CD20, very common is rituximab. The angiogenesis inhibitor we talked about being concerning for our use in cardiovascular patients is Avastin. And then Campath is a CD52 target, and Yervoy being the last one here. These have we'll talk a little bit more in a bit about some of these agents and where they fit and some of the adverse effects associated with them. Sort of as a review of monoclonal antibodies, the antibody itself really just brings together sort of 2 substances or 2 cells or antigens together to sort of bring them in close proximity for then to allow sort of something to happen. And a lot of the monoclonal antibodies used in cancer are targeted to, depending on the agent, to bring, maybe T cells or functioning to the cancer cell. And the end that is targeted on the cancer cell might be very specific for a different kind of cancer. So you'll find that there are monoclonal antibodies directed against a particular antigen on the surface of a particular type of tumor cell. And so the indications for each of these agents might be very specific for the DNA and the sequencing of the specific type of cancer and subset type of cancer or cancer markers. And so very commonly in this day and age, we want to look for markers or tumor markers, immunologic markers that are going to indicate which of these monoclonal antibodies or other treatment options are going to be more likely to have success in specific tumor types. Here's an example of some of the different types of monoclonal antibodies again, and what receptors they work at. There'll be sort of a repeat of these kinds of slides. Some of them associated with some bone marrow suppression, some actually having some emetogenic potential, some having varying degrees of toxicities, although sort of a global sense of toxicity we worry about with many of these monoclonal antibodies are hypersensitivity reactions. So we also see that some agents have specific roles or concerns for patients who have cardiovascular toxicity. We talked about that briefly with Herceptin and with Avastin sort of earlier. And we worry about those patients, for example, getting cardiovascular assessments done to rule out any pre-existing or complications to the therapy. So how do the monoclonal antibodies work? They may function sort of different ways, but they really work to flag the cancer cell and to trigger the body's immune response to bring that sort of a much more targeted approach. And depending on the nature of it, again, blood vessel growth, the angiogenesis inhibitors that affect development of blue blood vessels may make sense for a highly vascularized tumor, but would be, again, problematic in a patient with a coronary artery disease. They may also work to block a particular immune substance, so they may directly trigger the attack on a cancer cell, or they may deliver radiation therapy, they may deliver chemo. It's all, the agents, basically, we kind of look at the monoclonal antibody as a specific way to deliver something to a specific site. And that's really, the nature of the different monoclonal antibodies is as different as what they are targeted to. The nature of the common adverse effects, most commonly we think of hypersensitivity reactions, both significant and moderate in nature. Maybe nausea, vomiting, diarrhea, skin rashes, low pressure, blood pressures, the common other things you may see. Here's another sort of graphic that look at the common things you'll see, allergic in nature, but then some individual agents have very serious specific interactions that are specific to the agent. Bone marrow suppression for some and not others. Anaphylaxis risk is higher or lower with some. The risk for heart failure or something else, again, specific to the agent. So it really depends on the agent. And while this is not a hard and fast rule, the monoclonal antibodies generally, if they are more close to human antibodies, they are less antigenic. They're less likely to cause an immune reaction and a hypersensitivity reaction. The more close they are to a mouse or a protein, the more likely it is going to be a more hypersensitivity. All right, let's sort of look at sort of other sort of targeted therapies here. The kinase inhibitors, to which the major group here are the tyrosine kinase inhibitors. And these affect cellular signal transduction. More, you don't really need to get, in my mind, more complicated than that. Just regulate that these agents seem to regulate signals within the cell, and that really will, if they're targeted to a particular cancer cell, will sort of inactivate protein signal transduction signals that are protein related in that particular cell. There are many of the tyrosine kinase inhibitors. Gleevec is one of them, and the next slide has a number of them listed. We'll sort of let you look at that slide. There are also other targets. Examples include really both within oncology and outside of oncology, the mTOR targets that are sirolimus or everolimus that are used sometimes in other immune situations. Particularly, I think of these agents as used in organ transplant to prevent transplant rejection and an over-aggressive immune response. So they're used more as regulators in that scenario more than in cancers per se. The tyrosine kinase inhibitors, there are many of them, and the specific targets are different, and so the targets indicate the type of cancer types they're used. So I think what's important to sort of look at here in the big picture is to look at the tyrosine kinase inhibitors can be used in all different kinds of cancers depending on what they are. So, for example, you see in the leukemias for Gleevec, CML, you see them in ALL as well, acute lymphocytic leukemia. You'll see as you go down the list for non-small cell lung cancer. So, Iressa, commonly used for HER1 receptor specific lung cancers, non-small cell lung cancers. For the HER1 and HER2 receptors, you might see that used in breast cancers, depending on receptor sensitivity. You may see in thyroid cancers, depending on receptors, other agents used. So renal cancers, hepatocellular cancers, as you go down the list, colorectal cancer, depends on the target. So as you're looking at cancer targeting, you may see one of these tyrosine kinase inhibitors that is more specific to a match to the patient's cancer target and pathology. So pathology assessments of their tumor markers and biopsies and more fine-tuned assessments of those tumors are critical in determining which of these therapies are going to make sense for that patient. All in the purview of the oncology and the pathology division, sort of well beyond what most of us in primary care or hospital practice sort of would be focused on. There are a couple of slides here that go through what are some of the tyrosine kinase inhibitor side effects, and they really vary based on the agent. So what I think we can do is talk a little more maybe in class on these as well, but the adverse effects you'll see are sometimes Common in many of them, which you see in the common list on the left-hand column, are pretty non-specific. GI stuff, changes in endocrine thyroid function, or more serious things that are more usually more rare, thankfully, but might include pulmonary or thrombotic effects or bleeding or liver kind of toxicities. The next slide also includes, this slide includes some examples of other kinds of side effects, and they're kind of in small print, but you'll see that depending on the agent, some of them have a lot of pulmonary complications that manifest by fluid retention or pulmonary fluid accumulations and the like. So, depending on the agent, you see a whole host of side effects that may be either more specific or more general in nature. A next group of drugs that really is not sort of exactly like the monoclonal antibodies are the MIBs, the proteasome inhibitors ending in MIB. And Velcade is probably the classic example here. These inhibit intracellular proteins, and they have a specific role for the type of cancer that they're sort of directed against. So I won't get into more detail for that. But this graphic right from the package insert indicates the kind of side effects you'd expect to see here. And again, like we see with other things, we see different bone marrow suppression issues. You see sort of GI complications, and like you see hypersensitivity kind of reactions that can happen as well as headache and neurologic issues kind of as well. So, and infection suppression risk. So I think you kind of expect to see all kinds of things. What's often difficult is when patients are on cocktails of 3 or 4 or 5 of these different agents, and the side effect profiles are not dissimilar, then you ask the question of which agent it caused it or didn't cause it. So in the next cycle or whatever, which one do you sort of drop out of the mix? That's usually the purview of the oncologist to work with, and evaluating also what's the risk for that side effect, what's the grading of that. And I think the other thing, which I haven't really sort of alluded to, but this graphic does, is there is an oncology circles looking for toxicity of these drugs. They're graded usually as grade 1, 2, 3, 4, or higher. And what you'll see sort of in the columns to the under toxicity grades 1 and 2 usually are minor adverse effects, 2 mild to moderate. Grades 3 and 4 are more severe and incapacitating. And these often will require, when they're present, of interrupting future therapy for the patient and sometimes avoiding them entirely in the future. So, the oncologists really and their team really look at monitoring what these adverse effects are and the nature and severity of them, and weigh the benefit of the drug therapy against that cancer type against the risks and adverse and toxicity risks that those agents cause. For a lot of the agents that we're talking about in this group and the monoclonal antibody group, but otherwise as well, we worry about hypersensitivity reactions. Many of the monoclonal antibodies, that's the biggest risk. We've talked already throughout the curriculum about hypersensitivity reactions type 1, 2, 3, and 4, the most concerning being the classic type 1 IgE-mediated hypersensitivities. So how they may present type 1, a classic type 1 hypersensitivity that we're really concerned about is angioedema. We see this with not just these agents, we see it with ACE inhibitors, but we see it with monoclonal antibodies. And of all of them, rituximab is probably the one I think of as the most concerning here. Other allergic reactions you may see are all of the classic immunologic type 1 hypersensitivity reactions you might expect, and our management strategies are preventing it. Many of these drugs may require pretreatment with histamine 1 or histamine 2 blockers, maybe giving patients Benadryl or diphenhydramine in advance, as well as some patients may even manage either prophylactically or treatment with a glucocorticoid or management with a bronchodilator. This chart is a simplified chart of what some of the pre-medication recommendations are for some of the agents that are associated with more hypersensitivity reactions. And rituximab is probably the most significant here, where it is routine for a lot of these therapies that before they're given in the clinic, patients at least get acetaminophen and diphenhydramine in advance. Sometimes they add on top of that histamine 2 blocker, famotidine. All of those, all three of those are low risk agents that help sort of tamp down a bit any allergic reaction they may have. But you're really worried about an allergic reaction happening on the first or subsequent dose of any of these drugs. And so you want to have at the ready the full-blown anaphylactic management for these folks, with corticosteroids, particularly methylprednisolone, and an airway in place, and even epinephrine if they should need it. So all pretty serious stuff. Okay, the next timelines let's go through quickly are the cancer treatment vaccines. And I'll sort of short and sweet, one simple slide here. Limited use. There really is not a lot of vaccines that are specific for cancer treatment. It's hard to predict a response. There's not a clear role here. I think that the another way to think of this is not so much a cancer treatment vaccine as a cancer prevention vaccine is the human papillomavirus vaccine. That prevents HPV, which prevents all types of a number of cancers. But you really want to sort of look at those being an issue. But as far as treatment, cancer treatments are pretty limited in their role. On the other hand, the anti-program death 1 checkpoint inhibitors, these are monumental. These are major changes in immunotherapy. In conjunction with the monoclonal antibodies, sort of these two groups represent some major strides in immunologic therapy over the last decade or so. To sort of summarize this, there are subsets of cells. The program death 1 checkpoint receptor, the PD-1 checkpoint receptor, there really are subsets of 1 and 2 ligands, and these are each targeted on the particular tumor cell to sort of look at how the T cell interacts with that. And so if you can modulate either the T cell or the tumor cell to allow for more programmed cell death, all the better. And these agents have really sort of done a way to modulate that. So the PD-1, the anti-PD-1 therapy really work on targeting the patient's T cells per se to restore normal T cell functioning when that's been blunted or blocked by the cancer cell itself. So it allows the body to rejuvenate their original T cell response when the tumor itself has developed ways to blunt the body's tumor surveillance process. These are pretty advantageous therapies. There are a lot of them. Of the anti-PD-1 therapies, the first two are probably the most widespread agents that are used for evolving more and more different types of cancers. This is a common modality in lots of cancers, and a lot of different types of cancers in sets of cancers really will blunt the T cell response to that cancer for immunosurveillance. And these anti-PD-1 agents in a host of different cancers that are evolving into more and more indications every week, it seems, for these Opdivo or Keytruda have real roles in these types of cancers. So here's one for Opdivo. The first line use is for unresectable metastatic melanomas, for other types of adjuvant cancers and melanoma and renal cell cancers as well. But they're also used second line for a host of different cancers here and other uses as well, including the role in small cell lung cancer, non-small cell and small cell lung cancers, where they're pretty commonly used after some of the first line therapies. And so you'll see these agents more and more widespread in their use, and their role and indication in combination with other therapies becomes more widespread, it seems, by the week. The other monoclonal antibody affected here is Keytruda, which is used for first line for a number of indications here, or in combination with Opdivo, one of the other agents for metastatic non-small cell lung cancer, in combination often with chemo, classic cytotoxic chemo, and you can sort of see other indications here as well. Keytruda also has a number of second-line indications and has some other uses as well. So really key drugs here that have made monumental advances. The other approach for these agents are agents that, in a sense, work at a different sort of way, where they affect different ligands, PD1 or PD2. They include Tracentric, and they include Brevanco. Fewer indications for their use. Here's a third agent. Again, fewer indications, but is an issue. For all of the immune checkpoint inhibitors, though, there is sort of a set of adverse effects that are pretty common, including immune-mediated adverse effects, which include different kinds of side effects that are similar to what you see, both similar but different from the cytotoxic ones. Most often in these cases, what we see is a consistent risk for hypersensitivity type of reactions or GI toxicity. Inflammatory kind of reactions in the lung can happen. Thyroid changes can happen as well. And so all of these are sort of problematic. With these checkpoint inhibitors, the most serious include endocrinopathies. You'll see, thyroid or adrenal or diabetic issues or pituitary changes. You'll see nephritis, hepatitis. You might see hemolytic anemia or thrombocytopenias or aplasia with red cells. They vary based on the specific agent and the severity. The management of these are different from classic cytotoxic. Cytotoxic chemo, if you have these toxicities, the issue often would be, well, you can reduce the dose at the next cycle. In these agents, the answer pretty much is you don't do a dose reduction, you stop the drug. But then you need to figure out, do I need to, in addition, dampen the immune response, to which I use corticosteroids, or use something more specific if tumor necrosis factor is an issue, for example, with infliximab. And so the decisions to how we manage each of these based on the grade or severity of the adverse effect, the oncologist usually is the individual who works with the rest of the team to kind of manage or coordinate this. But your important issue is to recognize when these happen. So if with a checkpoint inhibitor you have severe dermatitis, and where they're graded by levels of severity with the severity of the rash and the intolerability and or consequences, we look at not only whether or not we hold the checkpoint inhibitor, but whether or not you get a derm consult, whether or not you initiate prednisone or something else. Okay? But derm reaction's pretty common with these checkpoint inhibitors. Colitis also pretty common with these agents. So you would expect to see, well, how often is the patient stooling? How severe is that? Is it resulting in incontinence? Is it causing bleeding or other kind of complications with the inflammatory complication? And then do you continue the therapy? Do you get GI consult? Do you have to stop the therapy? Do you consider corticosteroids or infliximab therapy, for example? Another sort of mediated effect is pneumonitis with these agents. And so again, based on the grading of the severity of their response, the clinician, typically the oncologist, is looking at, do we hold or not hold? Almost always hold the therapy. But do you get pulmonologist involved? Do you consider prednisone? When do you add prednisone? And when do you restart the checkpoint inhibitor or not, depending on severity? Thyroiditis, typically you look at their thyroid function test, the TSH, and that would often determine to the degree to which you would, hold the therapy or continue therapy, whether or not you would manage it with, thyroid supplementation or managing hypo or hyperthyroidism in a different sort of way. But if you have a patient on one of these agents for whom you're managing their thyroid status, you need to be aware they're on these agents and that you want to coordinate that with the oncologist for adjusting or managing their thyroid status. And then the issue of whether you use corticosteroid immunosuppression, there's some risks associated with that. So those are some of the things that are considered here. or with infliximab immunosuppression, some of the issues you might consider there. As far as the other agents, the main two groupings we've talked about that you're going to see a lot of are the monoclonal antibodies and the checkpoint inhibitors. The rest of the other two on here are pretty common. The oncologic viruses are fairly limited in where these fit. These are engineered viruses that are intended to replicate within cancer cells and spare normal tissue, but there's really not a lot we have here. There's one that's been considered and used in melanoma. I have no experience with this, but it's not a common sort of situation. And also not commonly seen are the CAR T-cell therapies. These are T-cell transfer therapies that harvest patients' T cells, but the problematic issue here is that they can lead to cytokine storm and CNS toxicities. It's hard to modulate those, and so they're not really a first line or standard therapy because it's hard to kind of pinpoint and manage those kind of toxicities.